pleasure being here. Sort of coming back home. I grew up in Lower Bucks County and was born at Abington Hospital. Of course, when I was born, it looked a hell of a lot different than it looks now. I can tell you that much. Well, I'm going to talk a little bit about lung issues in the neonate and why they're a little bit different than they are in the management of them than it has to do with adults. Now, if I can get this to work here. Disclosure, I am a consultant for Draeger, so I do help them with some things once in a while. One of the things that predisposes the neonatal lung to injury is surfactant deficiency, which leads to poor saccular compliance and atelectasis. A big issue is their compliant tracheobronchial tree, and we'll look at that in a minute, and their increased surface tension, and they have significant VQ mismatching. They have what's called an increased dead space to tidal volume ratio, and what that means in English is that when you deliver a volume to the neonate who has poor compliance in their saccules or alveoli, their airways distend dramatically, which is very different from the child and the adult who have fairly rigid airways that don't distend very much. Most adults, the dead space to tidal volume ratio in a sick lung is somewhere around 20%. In the neonate, it can be as high as 40 to 45%. So what that really means is that the distal airway is more distensible than the saccular alveolus, and that leads to injury, and it leads to interruption of it frequently, which can lead to PIE, pneumothorax, pneumomediastinum, and pneumopericardium. The interstitial space in the neonatal lung is much larger than it is in the adult, and because of that, it creates a place for fluid or air to collect, and then the air or the fluid can compress airways and make ventilation more difficult. What we found out in the baboon model is that hilum membrane disease is actually lung injury. It's not just due to surfactant deficiency, and I'll show you a slide of that in a minute. And this is what I'm talking about, dilated airways. Those very large open area that you see there are the airways of a baboon that's about a 28-week human equivalent who has hilum membrane disease. The pink stuff is all hilum membranes, and the saccules are all those little tiny dots inside of the pink space. So you can see that the airways dilate significantly, which makes it very difficult sometimes to ventilate and oxygenate babies without hurting them. We certainly know that ventilator-associated lung injury occurs both from peak pressure and volume. And why do I say peak pressure? Well, because when we use a pressure-limited ventilator, that's what you use. You use a peak pressure, which actually delivers a volume. So most people would now argue that lung injury is due to volume trauma, not specifically peak pressure. And that was worked out by several of these investigators who actually looked at lungs and basically demonstrated that if you have a normally compliant lung, the pressure is not the issue. The volume is the issue that hurts it. And this is a slide of our baboon model of hilum membrane disease, in which the slide on your right that looks very open is an animal that was given 1 hour of conventional ventilation and then 23 hours of high-frequency ventilation where the lung was kept open. The one on the left was ventilated with a conventional ventilator during that time, and this is no surfactant was given, and both animals are equally surfactant deficient. But when you tidal volume ventilate a surfactant deficient lung and you don't do it very well, you wind up hurting the lung significantly. Obvious, as we all know today, oxygen can be injurious to the lung. It is toxic to all tissues in 100%, even down to about 70%. Neonates have the big problem because they have lacks of antioxidant protection, particularly the preterm neonate. And what oxygen injury does, it perpetuates alveolar noncompliance and leads to using more and more pressure or volume delivered from the ventilator, which then predisposes the patient to further injury. That type of injury releases cytokines, which also perpetuate the injury for the baby. And so a lot of people today would like the term biotrauma. And that probably is a good term because it's a combination of ventilator, barotrauma, volutrauma, and the release of various mediators, which can be due to what you're doing with the ventilator. So you're misusing the ventilator or misusing it for the pathology you're treating, or it can be due to cytokines that are released because of high oxygen, released because of infection, and other issues such as that. So biotrauma probably is a very good terminology. And then the next thing is called epigenetics. And when one of my colleagues first, who works in the LAM lab with me, who actually runs the LAM lab, Kurt Albertine, said epigenetics to me, I was like, Kurt, what the hell are you talking about? Epigenetics what? What is epigenetics? And I'm thinking, genes that are wrong, whatever. Well, that's not what epigenetics is about. What epigenetics is if you do something to a structure in the body, and we're talking about the lung, so we'll talk about the lung, you can reprogram it to do something it isn't supposed to do. So, why do preterm babies who get chronic lung disease have decreased alveoli? Not because they were born to have decreased alveoli, but because we insulted them, and then that changed the way in which they alveolarize, and because of that, that's an epigenetic change, and so they are now programmed to not develop enough alveoli. Well, what are goals of respiratory support? And I think we all understand that achieving uniform inflation is critical for the patient, because if you don't have a normally inflated lung, you are applying certain pressures or volume to one part of the lung that is very different than you apply to the other part of the lung, and that can lead to injury to it. So we want to minimize over and underinflation. Remember that overinflation is not good for you, but atelectatrauma, underinflation, is equally bad for you, and in some cases may be worse. So we also want to minimize the amount of oxygen we use because oxygen is toxic to the lung, and we want to get off the ventilator as fast as possible. Lung recruitment, well, how do you recruit the lung? Well, you recruit it by typically increasing the mean airway pressure, which is accomplished by a number of mechanisms. You can increase end expiratory pressure, CPAP or PEEP. You can increase the inspiratory time that you're delivering the breath, which is what used to be done in the late 60s and early 70s. Inspiratory times of 0.6 to 1 second were not uncommon to get the lung open. Everybody gasps at that today. Why? Well, we have surfactant today. Are there babies who might need that occasionally? The answer is yes, there are. You can increase the ventilatory rate, you can increase the peak pressure, or if you're using a volume ventilator, you can increase the tidal volume being delivered. From a ventilatory standpoint, again, your choices are to deliver a bigger volume, which means you can either increase the pressure or increase the set volume for the patient. You can increase the rate. But again, one of the keys is what's wrong with the lung? And I think that's one of the problems we have today, is trying to figure out where are we on the lung and what are we doing with the ventilator that we're using from that standpoint. So, number one is when you make a ventilator adjustment, you should know what you expect to happen. When it doesn't happen, don't become what I call the dial twiddler, which is, it didn't work, so we'll twiddle up a little more of it. Didn't work again, we'll give them a little more till you blow up the patient, and then people are like, well, shit, why did that happen? You know? I mean, it's just one of those issues that you have to know, and when it doesn't work, you want to rethink the pathophysiology you're talking about. I give, most of you are respiratory therapists, as far as I know, but I give a talk called Respiratory Therapist More Than a Dial Twiddler, because you should be more than a dial twiddler. You should be there understanding what's going on and assisting people to know what's going on. And doctors can be a pain in the ass sometimes, to be honest with you. And how do I know that? It's quite simple. I married a respiratory therapist, and she used to tell me what a pain in the ass the doctors were sometimes, and they wouldn't listen. So I understand that better than anybody, and I get reminded of it on a regular basis. So, well, what kinds of ventilation do we have? Well, I grew up with intermittent mandatory ventilation. What you have to remember is that in the late 60s, IMV did not exist. When the ventilator fired, you had fresh gas. When it didn't fire, you rebreathed gas. All babies were ventilated at rates of 40, and to wean them from the ventilator meant you disconnected them and hoped they survived for 10 or 15 minutes, and then you put them back on, and then you tried it for 20 minutes, and then you tried it for 30, and then somebody said, well, shit, we'll try to take them off, see if they live. And some people argued that ventilating babies was no better than not ventilating babies. When IMV finally got invented in the early 1970s, the Baby Bird being the first neonatal ventilator that had IMV, you could actually do things with it. And then synchronized ventilation came about, but it really, people forget that synchronized ventilation came about early, but it didn't really work for the babies who needed it the most. Because imagine an 800-grammer having to generate enough negative pressure to trigger the device. So, as many of you who probably used it remember, you had the baby would be moving and the ventilator would be firing, and the ventilator could fire 80 times a minute, and the baby wasn't doing a thing but moving. So it really wasn't very good. Today, we finally come up with appropriate electronics and appropriate flow devices that allow us to now do synchronized assisted ventilation, either as SIMV or as assist control. Volume ventilation was the same way. The Bourne's LS10 whatever was a volume ventilator. The trouble with it was it had big compressible volume. There were lots of volume ventilators used in babies, including the MA1, which was an adult ventilator, that you had to set the tidal volume at 500 cc's to ventilate a preterm infant because the volume was so compressible and the tubing was much more compliant than the baby. So, as a resident, I was an expert at putting chest tubes in because I had the opportunity to put a chest tube in about every other day at least because people didn't turn the volume down very well. We do a much better job now to the point where some of my fellows have never put a chest tube in until they started their fellowship. So good and bad from that standpoint. But volume ventilation is particularly good at stabilizing lung volume, and you can improve ventilation perfusion matching with it. It does appear to stabilize cerebral blood flow because of that, and there has been some evidence with studies that you get decreased air leak from it. The problem is, remember that slide of the dilated airways? Where is the volume going? To the dilated airways, not to the alveoli or the saccules. So just because you use a volume of 5 per kilo doesn't mean you're delivering anything to the patient that will create gas exchange, because the last time I checked, airways don't exchange gases very well. Volume guaranteed pressure support, volume assured pressure support. Again, very similar to what volume does. It's just a different way to provide volume and to support the patient in breathing. So our modes of ventilation have improved in an effort to help the patient get better, to reduce air leak, to reduce barotrauma, volutrauma from that standpoint. MMV, a technique that's used in adults regularly, mandatory minute volume. One of its problems in the very tiny baby is that how does it calculate the minute volume, and when it isn't enough and it starts giving breaths, when does it stop giving the breaths? When it's very difficult for tiny babies to use that technique. And of course, there's high frequency ventilation. You can have high frequency positive pressure devices, flow interrupters, which is like the transport ventilator that I use from Dr. Bird, and his VDR is one of those. Jet ventilators made typically by Benell, and then the oscillator by Sensormedics. Well, what about pressure transmission with these types of devices? On the left side of your screen, you see the waveform of a high-frequency oscillator measured at the top of the endotracheal tube, at the bottom of the endotracheal tube, and out in the distal lung. And then you look at a conventional breath, and you notice that the high-frequency breath is attenuated significantly as you go downstream, whereas the conventional breath is not attenuated as much. Does that necessarily make one better than the other? The answer is not necessarily, but what it tells you is that you have to be careful of how you deliver things to the patient, because that's how you can create injury. From a ventilation standpoint, conventional ventilators are, as you well know, alveolar volume times frequency. High-frequency devices are the tidal volume that's being delivered squared times frequency. So while you use small tidal volumes, what you have to remember is that the small volumes make more to do with ventilation than they do with a conventional ventilator. So if you change something and you change volume, you have a much greater impact on ventilation than you do with a conventional ventilator. Oxygenation, and it really doesn't matter what kind of ventilator you're using, is typically defined by mean airway pressure, because mean airway pressure keeps your lung open, and that's the critical part of it. Does delta pressure play a role? Yes, it does, because if alveoli collapse, delta pressure reopens them. If airways are partially obstructed, you open the airways using delta pressure, either with a conventional ventilator or a high-frequency device. And then frequency plays a role. In the high-frequency devices, frequency plays a role because it creates air trapping. The faster you go, the more likely you are to air trap the patient. With a conventional ventilator, it creates inapparent PEEP. And one of the problems is, as people wean the ventilator when they've been on a rate of 60 and the patient's breathing more on their own, they forget that as they wean the rate, they also wean the mean airway pressure, and sometimes that allows for atelectasis and poor oxygenation. Okay, so now we're going to move on to different lung disorders and how you manage them. Because the key is to understand the pathophysiology of what you are treating and understand what the ventilator that you're using does and how it does it for that patient. So if you don't understand the pathophysiology, you will become a dial twiddler. And the first one is diffuse alveolar disease. Well, when I was brought up in neonatology in the early stages, we were taught that hyaline membrane disease is diffuse alveolar disease. It's all the same. The lung looks perfectly the same and that. And so when we were doing some of our studies in the baboon, we found out that that's not very true. Our adult colleagues later on proved that when they took ARDS patients and put them in a CT scanner and could demonstrate that this white lung was very white posteriorly, but not so white anteriorly, and that creates problems. And this is from our baboon model, and as you can see in the upper part of the slide, the lung is reasonably inflated, but in the lower part of the lung, it's completely atelectatic under those circumstances. And so that becomes the problem that you're trying to deal with. And this is a baby with significant RDS. And this is due to surfactant deficiency. This can be due to surfactant inactivation. It can be due to infection. What you have to remember is that babies born after 28 weeks today who have severe RDS have a very high risk of being infected, and so treating them is important for infection. So how do you recruit this? Well, obviously the best way we recruit it today is we give surfactant. And how do you deliver it? Well, there are the FDA approval, which is the 4-quadrant way. Some of us would deliver it right side down, left side down. Some people deliver it on the high-frequency ventilator. Some people take them off the high-frequency ventilator. Just remember that when you're delivering it, it's important to know where the endotracheal tube is, and it's equally important not to hurt the lung while you're delivering it. And I think that becomes important. But the key to managing these patients is to have an adequate mean pressure and adequate end expiratory pressure to prevent collapse. And before Dr. Gregory discussed and found CPAP and expiratory pressure, ventilators basically did not help babies because they were ventilated from 0 to 40 and back to 0. And when they got back to 0, the lung collapsed, and then they had to be reopened, and they hurt the lung. And so anytime you allow the lung to collapse and you have to reopen it, it creates a problem for you. There are other recruitment maneuvers that can be used. Size can be given. Prolonging inspiratory time can be done. One has to be careful of size, and the reason for that is that when we looked at our baboon model, it was a high-frequency model, so we would use a sigh for 5 minutes out of every hour to re-recruit the lung. And that was the only way we could create pulmonary interstitial emphysema in the baboon, was to sigh the baboon from that standpoint. And that sigh was being done by hand bagging them. So when you're giving surfactant, you want to be careful about how you hand bag them. And then having an adequate target volume is important. We have done a good job of not over-ventilating patients, not using too much volume. But one of the problems we get into is that sometimes we don't use enough volume, because it's sort of like, well, if 5 per kilo is good, 4 should be better, and 3 should be fabulous with that. But then you allow the lung to collapse, and you're starting over again. So what are the mistakes? I think the mistakes are inappropriate pressure changes. Either you wean the peak, if you're pressure limiting it, you wean the PIP too much, you wean the mean airway pressure too much, you don't use enough end expiratory pressure to maintain the lung open. And so it's very hard to say what do you use, what pressures do you use? And the answer is very difficult, because it's an individual thing. If you've given surfactant and the lung is compliant, you don't need much end expiratory pressure. 3, maybe 4 maximum. If they didn't respond to the surfactant, you may need 6, 7, 8 of end expiratory pressure. And again, the problem with the distensibility of the airways as saying, well, I'm giving this patient 5 per kilo tidal volume, the patient should be fine with that, and the patient isn't fine. Well, the patient isn't fine because you haven't opened the saccules or alveoli, and therefore you're just delivering it to the airways. I'm sure several people in here have seen a baby's chest moving, and the baby isn't oxygenating or ventilating. And the reason it's moving is because air is distending the airways, but it's not getting to where air exchange has to occur. And then some of these babies develop significant mucus plugging. And if you don't address that, it's a problem. This was a baby who was not doing very well. As you can imagine, looked very problematic. And we treated this baby with some dilute Mucomist and resolved his problem fairly rapidly. As you can see, had a chest tube on the left. And 2 days later, the chest tube was out, and the patient's lung looks much more normal with this because all of that overdistension was due to significant mucus plugging with that. Well, what about patients who have meconium aspiration? Well, meconium aspiration sort of comes in 2 kinds of patients. One is where they have this diffuse disease that looks more like RDS than it does meconium aspiration. And the other is where they have a patchy, very overdistended type of lung. Well, this is the baby with diffuse disease. And how do you treat this kind of a patient with that? Well, the patient has surfactant inactivation, so you treat it pretty much like you would with a baby with diffuse alveolar disease. Surfactant may be very beneficial in this patient, but remember that because meconium may be in the airway, you have to manage this a little bit differently because air trapping becomes a problem with that. And so you have to have a little longer expiratory times and slower frequencies in these kind of patients with that. And this is a baby with severe meconium aspiration who has a lot of air trapping and obviously wound up with a lot of air leak associated with it. So your goals for the meconium aspiration patient is to avoid overdistension and air trapping. You need to recruit atelectatic areas that are present. And so the basic strategy for it is lower rates than you would use for high frequency or conventional. One of the mistakes of people who use a high frequency device like an oscillator on these patients is using a frequency that's 10 to 15 hertz. Why do they use 10 to 15 hertz? Well, that's what we use on our preemies. That's what we use for everybody. As I've said when I give a talk on high frequency, I helped develop the oscillator, and if we didn't want the frequency changed, we wouldn't put a damn frequency knob on it. We would have just left it alone at one frequency. But we put a knob on it so you could change it, and you should be changing it. And for these babies with meconium aspiration, you ought to be using frequencies in the 5 to 7 hertz range, not in the 10 to 15 hertz range with that. And you need a little bit bigger tidal volume to open the airways to get stuff in so you can get stuff out. And again, as we talk, surfactant may be beneficial. So what are the mistakes with these kind of patients? Well, using tidal volumes that are too small, lung protective. Too rapid rates that predispose them either from a conventional or a high frequency device for air trapping, and preconceived appropriate tidal volumes for the patient. And many of these patients have severe pulmonary hypertension, and if you don't deal with the pulmonary hypertension, you're going to be treating pulmonary hypertension with high oxygen, which will hurt the lung and lead to worsened problems from that standpoint. Pulmonary hypoplasia. Well, it comes in 2 time types. There's called bilateral diffuse, okay? And there's a patient with bilateral diffuse. This baby had severe non-immune hydrops. So the baby had fluid everywhere, included within the thorax. This baby, I had tapped about 60 or 70 cc's of fluid off the lung before that x-ray was taken on the right side. So you can imagine how much problem there was. So the lung is small because it's been compressed, and because of that, it is easily injured. This is a baby whose mother had very prolonged rupture of membranes starting just before 20 weeks, and the baby gets delivered about 27 weeks gestation. And notice the issue here, the lungs look small. The lungs are relatively clear. If you're a rib counter and you would like the patient to be at 9.5 ribs, you will blow this patient up because this patient is clear at 8 ribs, inflation. And what that means is that once the lung is clear, it's clear. You can't make it more clear by over-distending it without hurting it from that standpoint. So you should maintain adequate inflation. You should avoid over-expansion of these lungs. And the preterm babies obviously need surfactant. Many of these babies will have significant pulmonary hypertension, which needs to be dealt with the various treatments that we have. From a unilateral standpoint, this one's pretty easy because it's almost always a diaphragmatic hernia from that standpoint. And the management for this kind of a patient is directed at the only lung you can direct it at, the normal, if it happens to be a left-sided, right lung, or if it's a right-sided, the left lung. What is critical for these patients is to avoid overexpansion of that lung, because it is the only lung you've got, and the baby's going to have to survive with it. The other lung will come up, it will improve over time, but the early parts of it all have to do with this lung. You want to prevent atelectasis from occurring. One of the big problems is somebody says, oh my God, the kid's 10.5 ribs inflated. We have to turn the pressure down. We have to turn the volume down. We have to turn the mean down. And they turn it down, and the patient was in 50% oxygen, now he's in 100% oxygen. And the reason is because you have to keep the lung inflated, and you have to remember that you have a lung from that standpoint. And if they're preterm, they need surfactant with that. And most of them have pulmonary hypertension. Pulmonary hypertension treatment, people have argued that nitric oxide is not beneficial to them. And the answer is that many of them have left-sided heart, their left heart function is poor. And because of that, if you use nitric oxide and you increase preload, the left ventricle can't tolerate it and the patient will get worse. So you have to fix the left ventricle first, but once you fix it, you can deal with their pulmonary hypertension with the typical medicines that we use. So I think the mistakes are using too large a tidal volume. That one thing you have to remember is that the tidal volume that you're using is only going to one lung. So if somebody says, well, we ought to be using 6 or 7 per kilo, that lung is really receiving twice that. So 12 to 14 per kilo, which is a lot of volume. So for a volume ventilator, typically you would start out at 3 to 4 cc's per kilo tidal volume with that. And again, if you don't address the cardiac or pulmonary hypertension issues with this patient, you will not fix them without a question. And then again, misinterpreting what is overexpansion. So rib counting, tidal volume are the big mistakes with this. From a severe air leak, from this standpoint, premature with PIE, And fortunately, we don't see a lot of this anymore. Back when I was a resident and a fellow, PIE was just part of being a baby on a ventilator. You know, that's the way it was. What should you be using? From a conventional standpoint, short inspiratory times. Because remember, the air leak in the neonate, unlike in the adult who gets PIE, is in the airway. It is not in the alveolus as it is in the adult. So they get a lot of air out, which is why their PIE becomes very diffuse and very problematic. So short inspiratory times create some turbulence in the airway and prevents it from going out the hole that's there. So long inspiratory times will allow more gas to go out. You need enough end expiratory pressure to keep the airways open, because the airways get compressed by all of the interstitial air that's there. And so some people think that, well, boy, when you have PIE, you want to turn the PEEP way down. And the answer is, well, you can do that. You can allow the lung to collapse. The patient will be in 100% oxygen. And then you have to get the lung reopened under those circumstances. But many times, if you just keep the airways open enough to exchange gas, the patient will do well. Typically using rates that are a little bit faster, up around 50, and tidal volumes that are on the small side, because you are trying to avoid further injury to the lung. With a high-frequency ventilator, typically we use a mean airway pressure that's the same or a little bit less than conventional. With that, frequency, rapid frequencies, 10 to 15 hertz, again, to minimize peak to trough pressures in the distal lung. And you want minimal chest wall movement with this, because you are trying to reduce the risk of lung injury. Well, gross air leak with adequate inflation, okay, and this is that. If you look at the right lung, it looks pretty normal. It's not too bad. It's a little bit streaky, but it's reasonably inflated, and the patient clearly has significant air leak on the left. With a conventional ventilator, using, again, short inspiratory times, you don't need a lot of end expiratory pressure because the lung is adequately inflated with that. Using rapid rates because you would prefer a little bit of turbulence so it doesn't go out the hole in the lung. And then again, using small tidal volumes. With the high frequency ventilator, gross air leak, mean airway pressure equal to or a little bit higher than conventional. So you don't need to be pushing the mean airway pressure on this. Rapid frequencies, again, because you're trying to avoid the leak into the lung area, and adequate chest wall movement. However, you know, the cookbook says air leak, fast frequencies, low end expiratory pressures, blah, 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 okay? But when your lung looks like a brick, you have to change your plan. So when your lung looks like this, on the right side, the baby has a pneumomediastinum. On the left side, there's a chest tube and a small pneumothorax. But the lung is a brick. It's white. If you use the low PEEP strategy, and that you are not going to get this patient inflated, and you are not going to oxygenate this patient, and you are not going to recover this patient. So, from an inspiratory time, 0.35 to 0.4 seconds, because you need to get the lung open a little better. You need a higher end expiratory pressure to prevent the lung from collapsing, a rate of around 40, and a tidal volume in the 5 to 6 cc's versus the 3 to 4 cc's. On the high frequency ventilator, mean airway pressure's got to be higher than conventional, and it could be as much as 4 to 5 higher. You can start out, I tend to start out low and then work up, because it's always easier to give more. It's always more difficult to take it away when you've created a giant pneumothorax in the patient. Frequency around 10 hertz, because again, you're trying to minimize, but remember, most patients who have pneumothoraces who are late preterm and term infants have them because they're infected. And because they're infected, they have airway disease. And if you use too fast a frequency, you will air trap the patient and you will make them worse from that standpoint. So many of the patients would wind up on being in maybe 8 hertz instead of 10 hertz. So I've tried to cover a bunch of different disorders with this, and I have a few take-home messages here. One is the enemy of good is better. And you know, as healthcare providers, we are never satisfied with the patient improving. We want them well because the parents want them well, and they want to know when they can go home. And so we're always tweaking to make them a little bit better. But if they're doing well, don't just keep squeezing more out of them, because you often wind up hurting them. And if you're going to apply ventilatory support to the patient and you don't want to traumatize the patient's lung, it's best accomplishing it by over the mid portion of the pressure volume curve. So this is a pressure volume curve of our baboon model. So the one on the bottom is a baboon that was conventionally ventilated, has severe hyaline membrane disease. So you can see that a lot of pressure doesn't give you very much volume. The one on the upper part is the high frequency animals, which kept their compliance more normal, so you could improve their ventilation with not nearly as much pressure from that standpoint. But the real thing to look at this is that once you get the lung open, you can back off on the pressure and maintain the lung still open. And so one of the things I always run into as a problem is that the baby gets recruited and is open, and no one wants to adjust anything on the ventilator because, well, you know, this patient was almost dying and now we've made him better, and so we have to leave him there. And then the baby's cardiac output starts to go down and the baby doesn't ventilate as well, and the baby gets overdistended, and people are forgetting that once you recruit the lung, you can back off on the pressure. And I think the previous person who gave a talk was talking about that during resuscitation. The question was asked, well, you give a few breaths of 30 centimeters of water and you get the lung inflated. What do you need to do now? We don't need 30 centimeters of water anymore because the lung's now inflated, and a baby's lung will be easily managed on 20 centimeters of water if you've inflated it. I've had the displeasure of doing some malpractice cases in which the baby gets intubated and people are using the lung protective strategy. 20 centimeters of water pressure. The patient's SAT is 50. SAT's still 50. SAT's still 50, and the patient arrests, okay? And the patient dies. And in one case, the physician told the family that the baby probably didn't have any kidneys and had severe pulmonary hypoplasia and died because of it. The family believed it, but when asked about an autopsy, they requested one because they knew that if the baby had no kidneys, their next baby might have no kidneys. And they wanted to know. And what happened at autopsy? Baby had 2 perfectly normal kidneys. And what did the lung look like? A brick, because no one had gotten a molecule of air into it. A baby who has never taken a breath requires at least 40 centimeters of water pressure to begin to open the lung. But if you keep giving 40 centimeters of water pressure, you will harm the lung significantly. But you do have to get the lung open in order for it to exchange gas. So that becomes a critical part of what is going on. So, issues with ventilation. A 5 cc per kilo tidal volume does not ensure prevention of overexpansion or injury. Why? Well, the why is pretty simple, because if 50% of your lung is completely atelectatic and you're giving 5 per kilo tidal volume and you haven't recruited any of that lung, you're really giving 10 per kilo to the lung that's open and you're overdistending it. What does a recruitment maneuver do? It opens the lung. How does it open the atelectatic lung? It opens the atelectatic lung by making the normal lung less compliant than the atelectatic part. And it does that by overdistending it to the point where it's no longer compliant, and then it opens the other area. So is that an okay thing to do? Yeah, if you have to get it open, it is an okay thing to do. But to keep doing it without giving enough to open the lung is not a good thing, because you keep overdistending the normal lung and you keep hurting the normal lung. And then a 10 cc per kilo tidal volume doesn't ensure overexpansion and injury, because some patients may need 10 per kilo. So don't leave here and say, Don Knoll said that 10 per kilo is a good volume for babies. It is not a good volume for babies. But on an occasion, you may need 10 per kilo. And the big thing is weaning. Everybody wants a baby off a ventilator, including me. And I would like them off at the very earliest possible time. But if you wean them and keep the lung on the lower portion of the pressure volume curve, you create atelectotrauma, and you will not protect the lung, you will injure the lung from that standpoint. So weaning has to be done to maintain reasonably normal inflation. As long as you do that, you will prevent lung injury. And this is the thing that you should always remember, that the neonatal lung is most vulnerable to injury during recruitment. So once you get it recruited, you better keep it recruited. Because if you let it go down and come back up, and let it go down and come back up, you will ensure that your patient is going to suffer some significant injury. And as respiratory therapists, you need to make sure you're tailoring your ventilator strategies to match the cardiopulmonary pathophysiology that you're treating. And that's what you should look at. And this is my favorite saying. Remember, cookbooks are good and everybody wants them, but patients are individuals. And we don't do enough individual care anymore. We are stuck in the cookbook. Well, this is how you ventilate a baby with meconium aspiration. Well, I'm doing it, he ain't getting better. Well, just keep doing it, because he will get better, or he will die. One of the two. So your goal is to prevent them from dying with that, because that's the real issue that you're trying to deal with, is that you have to go beyond what the strategies are. And I said to a group I was talking to the other day, doctors don't like to be told they don't know what they're doing. Okay? Respiratory therapists don't like to be told they don't know what they're doing either. Nobody likes to be told they don't know what they're doing. However, and this is true for most doctors, there are few who are so arrogant that they are never wrong. Reminds me of I have a friend who's a psychiatrist, and in his office he has a little plaque that says, "The only time I was wrong was when I thought I was wrong and I was mistaken." But the key is that you may tell somebody that this is what needs to be done, and they may just ignore you or suggest you're not right. and you know you're right. And one of the things that most of us do is say, well, I'm not talking to that stupid SOB again. It's not worth it. Never pays any attention, or she never pays any attention to me. Keep doing it, okay? That's my request to you. Because if you keep doing it, they will pay attention, and it won't be your idea the next time, it will be their idea. And then it's a good idea because it's their idea, okay? And with that, I will close, and I'm happy to answer questions.